Hello toppers, this is Medico Toppers. In this video, we will be discussing about surgical conditions of pancreas. And these are all the conditions we are going to discuss, mainly cystic diseases of pancreas, fistula, pseudocyst, ascites, and some pancreatic abscess and pancreatic fistula and some other things, except pancreatic tumors and pancreatitis. That pancreatitis and pancreatic tumors we will be discussing in next videos. First comes pseudocyst of pancreas. Pseudocyst of pancreas is nothing but this is a localized collection of sequestrated pancreatic fluid, and this is usually occurs after an attack of acute pancreatitis, usually occurs within 3 weeks of pancreatitis. And sometimes it can be occur after trauma or recurrent chronic pancreatitis also, and usually here the fluid collection will be seen in the lesser sac, and 20 to 40 percentages of this cyst will be resolved spontaneously. Also, this why it is known as pseudocyst, because it has no endothelium, only lined by fibrin layer. Also, serum amylase level is very high in pseudocyst of pancreas, nearly more than 5000 units per ml. And usually serum amylase is 200 to 250 will be normal, and amylase isoenzyme P is specifically increased in pancreatitis, but amylase CS is commonly increased in other conditions. Next comes types of pseudocyst. First one, depending on whether it communicates with pancreatic duct or not, it is classified as communicating pseudocyst and non-communicating pseudocyst. And another classification says about acute pseudocyst and chronic pseudocyst. It depends upon the duration. Next comes the HDO's classification. It has three types: type 1, 2 and 3. Type 1 occurs after an attack of acute pancreatitis. Here duct anatomy will be normal, there is no fistula or no communication. So this is occurs after acute of pancreatitis. Next comes type 2. This occurs after attack of acute and chronic pancreatitis. Here duct anatomy is abnormal, but there is no stricture. Next comes type 3. This occurs after chronic pancreatitis. Here anatomy is abnormal, also here strictures are occurring. Always it is communicating. It appears like a retention cyst, so it is always communicating. This type 3 is communicating. And usually this is sterile cyst. It contains typically brownish fluid with sludge like necrotic material. If it get infected, that may form infected pseudocyst or pancreatic abscess. Next comes pseudo-pseudopancreatic cyst. This is a mass in epigastric region. It occurs due to pancreatitis formed by bowel omentum like this. And clinically it mimics a pseudocyst of pancreas, but here fluid collection is absent. That is why it is known as pseudo-pseudopancreatic cyst. Next, other cystic lesions of pancreas. Mainly there are four types like true pancreatic cyst, pseudocyst, cystic tumors of pancreas and hydrated cyst. And usually pseudocyst occurs, and we have discussed about that. Cystic tumors we will be discussing in upcoming videos. True pancreatic cyst, it can be congenital or non-pre-malignant, and usually it is asymptomatic one. Here cyst can be associated with cystic diseases of liver, kidney and etc. Why this is called as true cyst? Because it is lined with cuboidal epithelium, and it usually associated with von Hippel-Lindau disease. Nearly 50% of patients are presenting with cystic diseases of pancreas also. Next comes cystic fibrosis. As we know already, it's an autosomal recessive disorder. Here the genetic mutation occurs in CFTR gene, which is located in chromosome 7. What is CFTR gene? Nothing but cystic fibrosis transmembrane conductance regulator gene. So it is located in chromosome number 7. It is common in Caucasians. It is inherited mutation, and it affects the pancreas, liver, intestine and sweat glands, and also male reproductive and female reproductive systems also, but usually here severe exocrine dysfunction occurs in pancreas. Why it is occurs? Because of it blocks the pancreatic ducts. Usually it produces high mucus production, so that will damages or blocks our pancreatic duct, that leads to pancreatic enzyme increases, so duct will be dilated, so duct ectasia occurs. So severe exocrine dysfunction, then if it occurs lungs, they will present with the features of chronic pulmonary diseases, and here it affects the sweat glands also, so elevated sodium and chloride levels in sweat. So these are the clinical manifestations. Mainly it affects our airway, it produces over mucus production, so that leads to obstructive manifestations like cough, dyspnea and anything. Next, it affects sweat glands also. Usually in active CFTR channel, sodium and chloride levels are normal. In case of this mutation, it affects mainly the chloride channel, that leads to mucostasis, and there is no mucus flow between these glands. So here occurs the sweat gland problems also. So high sodium and high chloride levels. Here the investigations are: DNA study should be done. Next, vomitus for gelatin study. In normal individual, vomitus contains trypsin, so that will digest the gelatin, so X-ray film will be white. But in case of cystic fibrosis, it won't occur. And according to the symptomatology, we can go for pulmonary function test, sweat sodium or sweat chloride test, or USG abdomen and anything. And if it affects intestines, child may present with meconium ileus, sodium deficit, sometimes cirrhosis of liver. Even usually these children are die in childhood or early age group. So these are the most important complications. Next comes annular pancreas, and this is an embryological malformation. So the pancreatic tissue encircles the second part of duodenum, that causes duodenal obstruction. So this is known as annular pancreas. It contains duct that joins the main pancreatic duct also. So mainly this is an embryological malformation. I hope you can able to see in this picture. The pancreas is fully encircles the second part of duodenum, and that leads to the clinical manifestations. So the main clinical manifestation or main symptoms are abdominal pain, nausea, bilious vomiting, visible gastric peristalsis, and usually it is often associated with Down syndrome. Even it can be associated with other congenital gut malformations also. And there are two types, one is neonatal type and another one is adult type. In neonatal type, they will be present with the symptoms of intestinal obstruction. In adult type, it presents after the age of 20, and they will present with the features of duodenal ulcer and bilious vomiting and etc. Here the investigation to be done is plain X-ray abdomen. There we can able to see double bubble appearance, because in case of duodenal obstruction we can able to see double bubble appearance. So in annular pancreas, duodenal obstruction occurs, so we can able to get this double bubble appearance. And in barium meal, we can able to see the obstruction at the level of second part of duodenum. Next, ectopic pancreatic tissue or accessory pancreas. And accessory pancreatic tissue may be seen in stomach wall, small intestine, Meckel's diverticulum, greater omentum or splenic hilum. Mainly it may cause upper GIT bleeding, and it may precipitate into susception, and nothing more than that. Next comes pancreatic divisum. As we had seen in annular pancreas, this pancreatic divisum is also an embryological malformation. In annular pancreas, pancreas encircles the duodenum, but in pancreatic divisum, problem occurs at the level of ducts. So here pancreatic divisum is occurs because of the failure of fusion of ventral and dorsal pancreatic duct. Here the problem occurs because of the major pancreatic secretion will be drained through minor papillae, so that will causes partial obstruction, so that precipitates pancreatitis. That is a main issue. Next, pancreatic calculus. Why pancreatic calculus occurs? Mainly pancreatic pancreatic secretion stasis or stricture at the level of pancreatic duct may leads to the formation of calculi in pancreas, and there are two types. One is calculi in the duct, another one is calculi in the parenchyma. If the calculi is seen at the level of duct, or if the calculi is seen within the duct, we may have the appearance of dilatation followed by strictures, and dilatation alternating with strictures. So that will give the appearance like chain of lake appearance. So this is more important, chain of lake appearance seen in pancreatic duct calculi. Next, in calculi in parenchyma, this occurs in pre-existing chronic pancreatitis patients. Because of chronic pancreatitis, gland is getting fibrosed, and that fibrosis leads to the formation of calculi. Next, pancreatic ascites. As the term differs, pancreatic ascites can occur in the patients of chronic pancreatitis, or it can be occur as a complication of acute pancreatitis or rupture of pseudocyst or any pancreatic trauma, and maybe it is associated with pleural effusion both side, but commonly on left side. And it ascites can be occur due to internal pancreatic fistula also. And by doing investigation, we can able to get very high amylase level and protein levels in ascitic fluids. Because of the leakage from disrupted pancreatic duct, we may get this high amylase or protein levels in the ascitic fluid, and we can do ERCP just to identify the leak, and CT scan are the essential investigations. Pancreatic fistula. There are two types, external and internal fistula. External fistula can be occurred because of Whipple's operation, pancreaticojejunostomy, spleenectomy, colonic surgeries or trauma, or because of rupture or infected pseudocyst, and etc. Here the main clinical feature is patient is in catabolic state and skin excoriations can be seen, electrolyte imbalance will occur, malnutrition and sepsis. These are the common features in case of fistula. And coming to the internal fistula, here the main problem is communicating pseudocyst, and pancreatic ascites, pleural effusion and enteric fistula can occur, and complications are mainly malnutrition, septicemia, electrolyte imbalance and etc. And there is no more MCQ notes about pancreatic fistula. Next comes pancreatic abscess. This is not common, only occurs in 5% people, and it can occur immediately after an attack of acute pancreatitis or an existing pseudocyst. And mainly this occurs in alcoholics and gallstone disease patient. Mortality is 25%, and pancreatic abscess is nothing but a collection of pus in lesser sac, mainly intra-abdominal, and it can be single or multiple, but mainly it is multiple, commonly seen in head or body of the pancreas. Abscess may rupture. If it gets ruptured, that may involve the viscera or other organs of abdomen. Clinical features are mainly pain in abdomen, tenderness, and commonest organism is E. coli. That is the main thing you have to remember. E. coli is the commonest organism. Next comes pancreatic necrosis. This is diffuse or focal area of non-viable pancreas, non-viable parenchyma of pancreas. Why it is occur? It occurs because of severe pancreatitis, or usually it can be associated with peripancreatic fat necrosis also. Here there are a few types like sterile necrosis and infected necrosis. Sterile necrosis is more common. Nearly 60% of total pancreatic necrosis occurs because of sterile, and here mortality is less. But if it get infected, mortality is more. And pathogenesis comes premature activation of proteolytic enzymes, intrapancreatic vessel thrombosis, pancreatic microcirculation failure, or release of any inflammatory mediators. These things can lead to the formation of necrosis. And mode of infection can be hematogenous or through ampulla or lymphatic route or anything it can be, but mainly it is polymicrobial, but commonest organism is E. coli. Next comes exocrine pancreatic diseases. Causes can be pancreatitis, cystic fibrosis, or pancreatic resections. Here, the investigations to be done are 72 hours of fecal collection just to estimate the daily fecal fat, because in case of pancreatic diseases, fecal fat will be more. That is why we are doing that. And we can do secretin cholecystokinin stimulation test and PABA excretion in the urine. And lung test, this is the most important one. Lung test, here duodenal juice will be collected 2 hours after meal, and here we are going to see the trypsin level. If the trypsin level is very low, that indicates chronic pancreatitis. That's all. We will be seeing about the pancreatic tumors and pancreatitis in next upcoming videos. Thank you.